Hi everyone. I wish we could be together today, but I want to thank you for allowing Brittany and I to join you virtually.
We are proud to help you recognize Diabetes Awareness Day in the Commonwealth and to continue to raise awareness for Kentuckians living with this disease.
As this group knows all too well, Kentuckians with diabetes have struggled to afford this life-preserving, in many cases life-saving medication. But last year, we took action. In the spring, I signed House Bill 95 into law, capping the cost of a 30-day supply of insulin at $30.
In January, the insulin cap went into effect, making a difference for so many of our Kentucky families.
It is truly a game changer for our people.
Over the past year, advocates like you have truly shown what can happen when we come together for the greater good of our people. Thank you for your dedication and compassion.
Yes, thank you. And I'm so proud of what we've accomplished for our folks living with diabetes and their families. And we'll continue to work to improve the lives of all our people when it comes to increasing access to quality and affordable health care, something I see as a basic human right.
And on February 16th, we will honor you and your work, and we'll continue our commitment to working on behalf of those Kentuckians living with diabetes.
So it's my honor to officially proclaim February 16th as Diabetes Awareness Day in the Commonwealth. I wish we could have signed it in person, but we will make it happen next year. Let's continue to make progress for our people together. Thank you.
Good morning, everyone. Hi, my name is Dr. Connie White. I'm the Deputy Commissioner for the Kentucky Department for Public Health and also a board member of the Kentucky Diabetes Network. When they asked me to do the welcome, they didn't tell me that I was going to be following such a great video. Thank you to the Governor and the First Lady for recognizing all of you on this Zoom screen and all of the work that you do. I wanted to be sure and just kind of give us a broad start. I know you know the landscape of diabetes and prediabetes in the state of Kentucky. 13.3% of Kentuckians in 2015 said that they had been diagnosed with diabetes, more than 1 in 10. And we know that 11% are estimated to have prediabetes. That 13.3% rate of diabetes in Kentucky is now double the amount in 2020. I'm sorry, 2000. We have a lot of work to do. One of the ways that we're working on this issue in many different ways with the department and with the Kentucky Diabetes Network is through working with public health. So everybody likes seeing pictures of babies. So I'm going to give you Public Health 101 today for those of you who haven't heard it. There were 3 sisters walking down by a stream. They looked over in the water and they saw a baby in the water, and they couldn't understand why there would be a baby in the river. So one of the sisters jumped in and grabbed the baby and pulled it over to the side of the bank. And then they looked and saw there's another baby floating down. So the sister jumped back in the water. The second sister helped her pull the second baby out. They're drying that baby off, and by now a crowd has developed. They looked around and there was a third baby in the water. They pulled that baby out. Everyone is getting upset. Everybody's getting worried. And they looked around and saw that their third sister wasn't helping. And when they looked to find her, she was walking back up the stream from where they had been pulling the babies out of the river. And they said, "Sister, why are you not helping us pull these babies out of the river?" And she said, "I'm going upstream to find out why babies are falling in the river." That's what we do in public health. We try to find out why those babies are falling in the river and what we can do. One of the great things that I've been a part of is our diabetes report. This is the 5th edition. Actually, my first week that I started with the Department of Public Health in 2012 was when we put together the 2013 first edition of this report. This is a wonderful piece of legislation, and those of you out there who worked to get this done know who you are. Thank you, Bob Babbage. But this is the legislation that was passed that required us to have a collaboration between the Department for Medicaid Services, the Department for Public Health, the Office of Health Data and Analytics in the Cabinet of Health and Family Services, and the Department for Employee Insurance, which is in the Personnel Cabinet. What that has done, that has been a model for the nation, but in Kentucky, it brought us all together so we could make sure we were all working in synergy. to make things on the state government level to work better. This is a statement out of a letter that was signed by the secretary of both the Cabinet for Health and Family Services and the Personnel Cabinet. They said the Kentucky partners must continue to work together to develop innovative approaches and strengthen evidence-based strategies to offer Kentuckians a life free of diabetes or the opportunity to live a healthy, full life. The commit in the executive summary, and you can find this on our website as well as it is in your packet. So the whole report is in your packet for your reading pleasure. But the committee identified specific goals related to strengthening diabetes prevention, minimizing diabetes complication, and improving the ability to have reliable data to track and understand the scope of this epidemic. And these goals are listed here. They're nothing new to any of you. Preventing new cases of diabetes, of type 2 diabetes, increasing screening. Many of you work hours and hours on this, trying to be sure that we are finding people with diabetes early or finding people who could benefit from pre-diabetes treatment and education. Working with our providers to increase and be aggressive with screening women in their pregnancies for gestational diabetes. We want to ensure that when we do find people that have diabetes, that they have access to diabetes self-management education and support. We want to be sure there are case managers to help them as they work through the complications of what do I do next? How do I make this better? What can I do to make it a better outcome for me and for my family? One of the reasons you're here today is we're talking about funding and how to sustain the work that all of you are doing, what we're doing in state government, what the foundation is doing, what the Kentucky Diabetes Network is doing, and all of the other work that all of you are doing in your local areas. And we also want to improve capacity and for the use of the surveillance systems and health information technology to determine the extent and the impact of diabetes. If we don't know where we started, we don't know if we've gone in a positive direction or not. And collecting that information is absolutely critical for us to measure where we are going forward in all of this amazing work. I also wanted to share with you some information that staff at the department shared with me this week. The Kentucky Prescription Assistance Program that many of you are familiar with, and I think that'll be discussed later today, where we assist people who cannot afford medications to get free medications sent to them. These are the top 10 medications that we assisted clients with in the state of Kentucky this year that needed help paying for their medicines. And you can see several of those medicines are directly related to people with diabetes. So I wanted to just welcome you today. I wanted to thank you for being here. I wanted to thank you for your work at the state level, at your local level, whether it's going to your provider and making sure your providers know the guidelines for diabetes, encouraging family and friends to get that eye exam. Make sure people are clear and understand the importance of that foot exam, working with your local clubs and agencies and local hospitals, anybody who's there to listen, to be sure they know the message that we as diabetes advocates want to spread across the state of Kentucky. So thank you for being here today. I see that Representative Minner is on, so I'm going to go ahead and cut my welcome short because I think what the legislators have to say to us today is extremely important. Thank you again for what you do. Bring more people with you next year so we can spread more people out as we kind of mass a front of people saying diabetes increases the cost to our state and the cost to the lives of the people and their families that work with this disease. So thank you for letting me be here as part of this introduction. Thank you to the foundation, and thank you to the Kentucky Diabetes Network for again hosting this meeting. And everybody is going to learn so much today and leave with a whole lot of knowledge and information that they can share with their legislators, with their peers, with their coworkers, and with their families. So I'll turn it back over to you.
Thank you, Dr. White. Good morning. I'm Merritt Bates Thomas, a past president of the Kentucky Diabetes Network and Community Outreach Action Team co-leader with Pat Ryan. Once again, we're gathered virtually like we were last year. And while we're not together making legislator visits today, the information shared by our panel of speakers can guide us to have more informed conversations with our legislators. Remember, your voice matters. After today's event, please reach out to your legislators about the importance of the legislation being highlighted today. Our first speaker is a familiar face to Diabetes Day at the Capitol. Representative Patty Minter is from Bowling Green and represents the 20th District in Kentucky's House of Representatives. Welcome and thank you for being with us, Representative Minter.
Oh, well, thank you so much for having me here this morning. And it's wonderful to see so many advocates that I've worked with before. And after you hear from me, you'll hear from my dear friend, Representative Danny Bentley. And it is a joy every day to do this work with him to make sure that Kentuckians have access to the insulin that they need to live. And we're going to talk about supplies today as well. But by way of introduction, again, I'm Representative Patty Minter, and I represent Bowling Green's House District 20. And thank you all for asking me to speak today. And thank you from the bottom of my heart for the support of the Kentucky Diabetes Network and the Kentucky Academy of Nutrition and Dietetics. Last year, you all supported House Bill 95, and it sailed through without a single no vote in the General Assembly. And everybody on this call knows how hard that is to do, but you did this. You let your lawmakers know that it was time to take steps to make sure people had the life-saving insulin that they need. And there's nothing that makes me happier than getting emails or seeing posts on social media from someone who's got a picture of their insulin saying, my insulin costs 2/3 less. That's the average number I'm hearing, 2/3 less than it did this time like last year. And again, thank you all for helping push HB 95 across the finish line. And there's my friend, Representative Bentley. As a lawmaker, I want to make sure that all Kentuckians have access to life-saving insulin that they need to survive so that they won't be thrown off their insurance. I also advocate for making sure that people with pre-existing conditions are protected. And that's something that I would love to work on next year. But for me and for all of you here, these issues are not theoretical. They're not just facts on a sheet of paper because they're personal. As the mother of a son who is now 16 years old, who lives with type 1 diabetes, I know firsthand how necessary it is that we pass these bills. In November of 2006, my life changed forever when my son's daycare called to tell my husband and me that there was something wrong with our child. His pediatrician, who also lives with type 1 diabetes, recognized it immediately and told us that Alex had type 1 diabetes and that he was in diabetic ketoacidosis. And we needed to get to the hospital as fast as we could. When that happened, Alex was only 19 months old. He spent 3 days in the PICU at Vanderbilt Children's. And it's an experience that I would not wish on another person. And during that 3-day period, my husband and I learned to take care of a toddler who was insulin dependent. I will never forget, and for the rest of my life, I will always be grateful to the nurses who told us it was okay to be sad, but that he and we were going to be okay. I am forever grateful to the certified diabetes educators. Before this, I had not even known such people existed, who taught us how to care for our son. I am grateful to the nurse practitioner who patiently taught us how to draw insulin, who explained to us what Novolog and Lantus do in your body, how to calculate doses, and she taught us how to inject each other with saline until we could do it correctly. I'm grateful to the dietitian who taught us how to carb count. And when Alex came home, They supported us in person and on the phone, long before the word telehealth was in anybody's vocabulary. As I said, Alex is now 16 years old, and I watched the price of his insulin soar since 2006, and I realized how different everything would be for him if not for his access to insurance and to insulin. He now uses 3 vials of Novolog a month, and because of your support for Representative and Bentley's and my HB 95, his insulin now costs 2/3 less than it did this time last year. But everybody who's here today knows that HB 95 was a great start, but it is not the end. And many Kentuckians still don't have the security that insurance brings. So that's why we're here today. And that's why I'm so proud to work with my friend Representative Bentley to pass House Bill 42 and House Bill 90 as soon as we can. All of you know we have to pass HB 42 because lives depend on it. HB 42 is ALEC law. I always have to say ALEC, not ALEX like my son. But ALEC law will change lives here in Kentucky the way it already has in Minnesota and in Colorado. And this week, Illinois is holding a committee meeting with the support of the American Diabetes Association and the Insulin for All chapter in Illinois. Folks, Kentucky needs to be next, and with your help, we will. Again, I'm proud to join my colleague, Representative Danny Bentley, on this bill, and our advocates have told us several things. First and foremost is there is need. We need ALEC law. One of them said, I needed ALEC law years ago. One of our advocates has told us that she's walked out of pharmacies with tears streaming down her face without insulin or supplies because she had inadequate insurance to pay for what she needed. And all of you know that insulin rationing causes so much harm to people who live with type 1 and type 2 diabetes. Advocates tell us they've spent days and weeks arguing on the phone with manufacturers, begging for coupons or any assistance to obtain the insulins they needed with no luck. And so many jobs and industries, and we're certainly seeing this because of the pandemic, are never a sure thing. And COVID-19 is the latest thing to put jobs and people at risk. So ALEC law, HB 42, will create a safety net for someone who loses their insurance or if formularies change. And we know that happens all the time. What HB 42 does is it takes power out of the hands of insulin manufacturers to decide whether or not someone has access to insulin. It takes time to get Medicaid approval. It takes time to do paperwork after you've lost a job. And in the meantime, you still need your insulin every day. So the immediate 30-day supply of insulin that HB 42 will provide gets someone who is insulin dependent through this tough time. So we need to pass 42 now. It is not yet a safety net that would guarantee insulin for all, but it makes a stronger safety net than what Representative Bentley and I were able to do with your support in House Bill 95. And it gets us closer to being able to one day have access to insulin for all. And I want to talk about House Bill 90 again. I'm so grateful to my friend Representative Bentley for bringing this to us. He'll talk more about it, but this is already passed in neighboring West Virginia. And if you can pass it there, I say we can pass it here. This caps copays for supplies and medications, not only for people who live with type 1 diabetes, but it also covers medications for people who live with type 2. And lots of people have asked me about, well, what about type 2? What are you doing for type 2? Meaning people who are not insulin dependent. And when Representative Bentley told me last summer what had happened in West Virginia with their supplies bill, it seemed like the answer to a prayer. And we have to pass HB 90. And again, why? Because lives depend on it. While the Affordable Care Act protects Kentuckians from losing health care due to pre-existing conditions, and again, that is still subject to the whims of federal courts, to lawmakers in Congress, and what's going on in the White House. But we need to make sure that people will have access to the testing supplies that they need. Representative Bentley is going to take you through some of the finer points of HB 90, but we have to make sure that people will have access to testing supplies so that they can check their sugar. And again, expanding it to include some of the medications for type 2 diabetes. So together, these bills, which desperately need to pass, will help get us closer to having access to insulin for all, making testing supplies and syringes and medications for type 2 diabetes as well as type 1. It will make it so much more accessible for Kentuckians. No one should have to lose a limb, their vision, their kidneys, or their life because they cannot afford the insulin, the medication, or the supplies they need, not just to live and not just to survive, but to thrive. So I am very, very grateful for your help and your advocacy as we try to move these bills into committee and get them to the floor for the vote. So if you want to help us save lives, please, please call your lawmakers. And you can send us emails too, because it's good for me. And I know it's good for Dr. Bentley to be able to say, hey, we've gotten 100 emails from people in our districts that need these bills to pass. But if you want to help us save lives, let's pass House Bill 42 and House Bill 90 and share your stories. Whether you live with type 1 or type 2 diabetes, or you're a CDE, or you're a dietitian, or you're a nurse or an advocate who wants to make sure that people with diabetes have access to the medications they need, please share your stories. Tell your lawmakers why these bills have to move, and they need to move right now. This legislation won't end diabetes. It won't end the struggle that all of us have felt, but it will make the hard days a little easier. And for those of us who are here today because they live with diabetes, for those of us who have loved ones who live with diabetes, and for every Kentuckian who lives with diabetes, this is a wonderful place to continue the work we began last year with House Bill 95. So in closing, I want to thank all of the educators, dietitians, CDEs, advocates who are here today. Thank you for your wonderful work. Thank you to my friend, Representative Bentley, who makes it a joy to do this advocacy work.
Thanks.
And thank you for allowing me to speak with you today. And I'm going to turn it over to my dear friend, Representative Bentley.
Thank you, Patty. Very thorough. Thank you very much. I am running 4 different things at one time. You saw me looking at my phone. So I'm supposed to be speaking at 9:15, 11 o'clock. Today is Diabetes Day, KPHA Pharmacist Day, Mason's Day. So I don't know if we'll get any law passed or not. There's so many things going on. And then someone in the hall, you know, once a pharmacist, always a pharmacist. They gave me the profile 1 minute to tell them if they had any drug interactions. So it's been a busy day already. It's like Patty said, it's a joy to work with her on Alex bill. I was talking with Pharma yesterday, and I said, give me a better plan than what I have. So I don't know what's going to happen to that thing this week yet, for sure. But on 90, it may come up this week on committee, if with a little luck, because we've negotiated that down, the price. Gary, in most states, isn't the deductible $100? Gary, you in there?
Yeah, it varies among states, Representative Bentley, but the ones who have passed this, most of them are $100.
Well, if I get mine and Patty's passed, it's gonna be cheaper than that. So that's a score for the working man and woman out there, especially today in this crisis. So that's where I am right there, and that's what I've been doing this morning, working on those things. Patty's give you a good overview of everything that we're doing, but the finer details was I'm still talking with Chair Lady Moser, and her agenda will come out later today, so we'll know what's going on. Alex bill may not come out till next week. Way we're negotiating with people. You know, a lot of people that's never been in this process doesn't understand the process. Now, Ben Chandler, I used to watch him work. Believe it or not, he worked up in DC. Didn't you, Ben? Come on, Ben, say something. Turn your microphone on.
I sure tried, Danny, and I enjoyed seeing you. And I tell you what, you have been such an incredible advocate for this issue. I mean, whenever I think of diabetes and what we're going to do about it, you're top of mind, and we sure appreciate it.
Well, let me tell you what Ben did to me out there in Washington, D.C. He put me out in the hallway. And so I was with Debbie, the dean of the pharmacy school up there in Findlay. And she looks kind of like Allison, had frosted hair, had a trench coat on. So I turn around, get ready to go down the hall, and this lady shrugs me off and it was Hillary. It wasn't Debbie. They both had frosted hair, same height. So we've laughed about that ever since, what, 96, I reckon, 20 years.
Yeah. Well,
we've been walking the halls in Washington for a long time.
Well, and I had to put you out in the hall, Danny, because I was multitasking like you are today.
Yeah. Ben was good to me in Washington, and he's a good advocate for diabetes also. Thank you, everybody, for tuning in. If I have to get off here, it's just because I got a heavy load today. And Patty will take care of any of the questions. She's well informed and doing a good job, Patty is. Does anybody have any questions for me?
Representative Bentley, this is Allison. We would just like for you to tee up the video, the pay or die video. If you could just say a few words about that, and then Alexandra will share that with the group.
I'm on a new computer. Yeah, it's the wrong guy, Allison. Let me see if I can find it.
You don't have to tee up the video. We got that. If you just want to share a little bit about it.
Oh, okay. Well, this is everybody knows Pay to Die, film.com, is going to be a documentary by Netflix in 2023. They came to Kentucky and they interviewed me for a couple hours, and then they interviewed Honorable Booker, because he's type 1 diabetic, and so that'll come out 2023, and it'll be a good thing for Kentucky, and so that's what that's based upon. Netflix is doing that. So if you go there and watch that video, I was hoping if we get to Health and Family Services, that Patty and I can put the arm lock on our chair lady and let that be seen in the committee meeting too. Yeah, all right. So, anything we can do to help people with diabetes, I still have those vivid images in my mind of people coming in, getting their insulin and going next door and getting their Milky Ways and Pepsis. So, Eastern Kentucky needs to be educated a lot more. I'm so tired of us being in the 40 out of 50 on stroke, obesity, drug crisis. So we're trying to do all we can here. And I appreciate Patty doing all she can in Western Kentucky too. And everyone here does their part. I'm preaching to the choir, I know. But I've got to go down and speak to the other place. And thank you all for zooming in. Anything I can do to help y'all, or you have any ideas, come to Patty or I, and we'll take care of them. So all I can do today. Thank you, Allison. Good to see you.
Thank you, sir.
Everybody I can see, I said hi to. Ben, Allison, Gary, Patty. Everybody else that's got foundations up there or something. Hi, Whitney Allen. Hi, Kate Thomas. So, okay, Ben, stop and see me next time you're in.
We'll do it,
Yeah.
Danny, and thank you so much for all you do. And Representative Minard too. You guys are such champions.
Well, we just want to help the less fortunate.
Yes,
That's
you do.
exactly right. That's
Okay.
exactly right. And until we can turn type 1 and type 2 into type none, we are glad to do this work with you to make sure that
I'm Eric.
people have the insulin and the medications and the supplies that they need. So thank you all for helping us get this across
Okay.
the finish line.
My secretary's pulling me out here now.
Thank you all so much.
Bye-bye.
Bye-bye.
Bye, y'all. Stay in touch. Thank you for your work.
Growing up, Alec was busy.
Alec, come here, baby boy. Oh.
He always had to be doing something, and that never went away. You know, when he first got sick, he didn't dwell upon it. He didn't get angry. He was just, I'm a type 1 diabetic, so I guess I have to deal with this. Alec died from diabetic ketoacidosis as a result of rationing his insulin.
Here in America, it will not surprise you to know that we pay the highest prescription drug prices of any developed nation in the world.
Since 2008, 3 top manufacturers raised the list price of insulin at least 10 times.
The insulin was not affordable. He thought that he could make the little bit of insulin that he had left last until he got paid.
My mom and I walked into Walgreens. The cost of insulin was too high for us to afford. And so we had to walk back out without it. It made me feel like because we didn't have enough money, I was going to die. And she was like, what are we going to do? It lit a fire in me. So I made it a priority to fight against the rising cost of life-saving medication.
Insulin is the 6th most expensive liquid in the world.
It actually cost $113,000 a gallon, and it's grown. It's now the 5th most expensive liquid in the world.
It's in the company's best interest to continue raising these prices. It's not in the best interest of patients.
I've got the secret to insulin pricing. It's in the black box. They spend millions of dollars to make sure the box stays closed.
Healthcare costs are so expensive that 10 years of savings could be used up in 1 month. It made me realize unless we have major reforms, this was not sustainable.
My counseling for patients with diabetes now includes a lot about how expensive this condition is going to be for them.
I don't want to be concerned about money. I don't want to think about it. I'm choosing not to think about money because I want to figure out how to live.
Alec was working and making a life for himself. Alec did not have insurance because he made too much money to qualify for a subsidy, and the plans that were offered were absolutely not affordable.
I just get nervous with health insurance companies and how they're going to take care of me.
If someone out there is struggling with insulin affordability, it's black market resources.
I'm going to pick up some insulin. Some of that insulin is expiring.
Are you down for what?
Mom and I both have type 1 diabetes. 4, 5.
There was a time that we lived in our car. If Emma was with us, she would sleep in the back, and then we were in a homeless shelter. We had nothing. It's still easier to go to Canada and get insulin. In Canada, I'll be spending $514 at home. It's $2,750. It's crazy.
To get the broad scale change that we need, it can only come through public pressure.
Hydrate prices got to go!
You have to say the same thing over and over and over again to get people to really understand this is real, this is today, and we got to change the system.
There are a lot of people that are trying to survive. We need to finally prioritize the most important aspect of our economy and of our country, the people.
They blame consumers because you didn't find the rebates, the coupons, and they don't seem to care.
If there's enough of us raising our voices and demanding justice, they're going to be forced to change the way they do business.
Justice for Alec! Justice for Alec!
thank you again to Representative Minter for being with us, and thank you to Representative Bentley as well, and their collaborative work to make the lives of people living with diabetes better and healthier. Representative Bentley is from Russell, Kentucky, and he represents the 98th district in Kentucky's House of Representatives. Our next speaker is Kate Thomas. Kate is the Chief Advocacy and External Affairs Officer with the Association of Diabetes Care and Education Specialists. ADCES is an interprofessional membership organization with more than 12,000 members, including nurses, dietitians, pharmacists, and others, all dedicated to improving prediabetes, diabetes, and cardiometabolic care through innovative education, management, and support. Welcome, Kate.
Good morning, Merritt, and good morning, everyone. Thank you so much for having me. I do have some slides this morning. Is it best if I share my screen? Oh, wonderful. Thank you. And it's so powerful to hear all of the work that you are doing here in Kentucky. When I saw the agenda for today's program, I was just absolutely floored at the speakers lined up and the number of participants and all of the excellent work that you are doing. So thank you so much for having me. Next slide, please. And I think we're a couple more slides in.
I think we need to go back a few slides. These are Kate's slides from ADCES, and the slides that are showing are toward the end of the presentations.
And while we're waiting for the slides, I can talk a little bit about some of the things that are happening in Congress right now. I think, as we know, Congress and both the Trump and the Biden administrations have been looking at drug pricing. And so we've been really trying to focus on what can be done at the federal level and what some of those implications look like, or provisions to change drug pricing. And additionally, I'm going to cover this in my presentation, but the National Clinical Care Commission, which is a federal commission that was formed by Congress that took 3 years to go through its charge, looked at federal diabetes policy across all federal agencies. They have a number of recommendations as well that impact all aspects of how diabetes care is delivered in the US. So it's really interesting to see that report and what we can do with it in terms of advocacy. Would you like me to share my screen? Is that easier to pull up my presentation from where I am?
I think that would be best. You should have permissions now.
Okay, great. Thank you. I'll give it a try. Okay. Can everyone see my slides?
Yes, ma'am.
Okay, great. Well, so thank you again. And I covered who I am, but I wanted to just talk about, I'm from the Association of Diabetes Care and Education Specialists. Again, my name is Kate Thomas. And I wanted to talk about advocacy at the National Association because it really ties in nicely to the work that you're doing in Kentucky. And certainly all individuals who are involved with advocacy work, whether that be at the local, state, or federal level, play such an important role in what we do. So at the association, we look at advocacy in a couple of different ways. So we spend a lot of time focusing on advancing federal legislation. We also look at how we can change regulations. We know that if anybody here provides Medicare services, there are a lot of things that must be updated with the Medicare program to make it easier for providers to deliver services and for individual beneficiaries to access services, to afford services, to navigate the system. So we work a lot on that. We also look at reimbursement and payments. So how are services reimbursed? Again, we're a provider-focused organization, so this is something that frequently comes up for our members. We also support state-level initiatives, which is so wonderful to hear what you're doing in Kentucky, and certainly inspiring for other states looking to do something and to do some training and talk about advocacy. We do a lot of relationship building as well. As I've seen from the speaker list and from the events plan today, I know Kentucky is top for relationship building and connecting everybody. And that you'll see in some of my later slides, this is a really important part of our work in terms of working with other coalitions and working with other organizations. And we want to grow our network. We need to make sure that our voices are heard, and that includes building our network of advocates. And we are a relatively small organization in terms of advocacy, so this comes into play and it becomes really important. So we use collaboration and partnerships to broaden that reach. So individual diabetes care and education specialists and advocates like yourself really, really are critical to what we're doing. I hear from people sometimes saying, I'd like to help, but I don't know how to get involved. And so today I'm going to give you a few suggestions if you'd like to get more involved with advocacy. I also think there's room for all different types of advocacy. So maybe you are a person with diabetes who's advocating for changes in policy, or you're a diabetes care and education specialist or other provider who's advocating for somebody within your own organization or your own hospital system. It takes on, or you're meeting with a member of Congress or a state legislator. It takes on all different shapes. And so we have state coordinating bodies, which I know that many of you are familiar with in Kentucky. We have some national committees. We have an advocacy committee and a practice management committee. Again, we work with different coalitions. We're part of the Diabetes Advocacy Alliance. It's a national coalition. I co-chair that with a colleague from the Academy of Nutrition and Dietetics. We have we've got almost 30 members right now, and we do coordinated efforts on Capitol Hill and with the federal agencies to get some policies changed. And then certainly work with many, many others in the space. And here are just a list of the coalitions that we're part of. We've recently joined some technology coalitions, and I'll talk about some of the aspects of that because we've had some pretty good success. And as I'm sure many of you know, it's talking with this collective voice in the advocacy space, really bridging that gap in terms of other organizations that might be working on similar things. That's been really beneficial to us. We're also part of the Obesity Care Action Network, recognizing that we see a lot of similarities or shared advocacy goals between preventing diabetes, obesity, and some of the other chronic conditions that impact people with diabetes or type 2 diabetes or those at risk for diabetes. And so just a brief example of some of the success we've had in working with our coalitions and other partners. We've been really advocating before Medicare to change some of the coverage policies related to coverage for continuous glucose monitors. And as of July, we were really excited to see that CMS and the local coverage determinations, which oversee these policies, had removed the requirement that people with diabetes check their blood glucose 4 times per day in order to be eligible for CGM. And this was something that I remembered bubbled up a few years ago because Medicare was requiring people to test their blood glucose 4 times per day, but was only covering strips for 3 times per day or supplies for 3 times per day. And so this was really coming to a head a few years ago when pharmacies, some of the bigger pharmacies, stopped filling those orders. And so it became really problematic. And we worked with a lot of different partners to get this changed. And I know it's a relatively small change considering all of the many, many things that need to be improved in terms of advocacy and coverage for diabetes. But this was a really great example of people working together to make a difference. Here are some of the advocacy priorities that we've been working on at ADCES. As I mentioned, we do a lot around legislation, but we really have a focus on all of our advocacy work to support health equity through policy. So we're really focusing on policies that will increase access for people with diabetes that may not have it, address some of the disparities that we know exist in diabetes care, And some of this trickles down into our legislative work, or all of it trickles down into our legislative work. But we do a lot of work around improving the Medicare benefit for diabetes self-management, education, and support. This is known by Medicare as diabetes self-management training. So everybody really refers to diabetes self-management, education, and support as DSMES. Medicare refers to it as DSMT. So if you hear me say DSMT, that's what I'm referring to. And we know that this is a benefit that's been in existence for over 20 years now, and it hasn't been really looked at or updated in that time. And anybody that's delivering the service knows that the things need to be changed, it needs to be updated. And so we've tried to do this in a number of different ways. We have a piece of legislation, the Expanding Access to Diabetes Self-Management Training Act, which has been introduced in Congress, both in the House and the Senate this year, or this Congress, that looks at changing some of the things in the benefit that must be addressed by law. We also have regular conversations with Medicare to see about updating regulations or guidance. And so those conversations always take place. And then we also have done things like looking at the national standards for DSMES. You may have seen that the new standards were recently published. It was a joint effort between ADCS and the American Diabetes Association, both of the national accrediting organizations for DSMES. And we looked at ways to reduce some of the administrative burden for DSMES programs and services. So that these are just some of the ways that we're looking to improve the benefit. We recognize things like cost sharing requirements that require beneficiaries to pay a copay for DSMES. These are problematic. So those are some of the things that we're looking at to do by legislation. We also work on legislation that seeks to add virtual Medicare diabetes prevention program suppliers to the program. Currently, virtual suppliers can't participate in the Medicare diabetes prevention program. So we're seeking legislation to improve that. There's also a number of different telehealth bills that we're working very closely. You may know that during the pandemic and currently, there were some telehealth flexibilities that allowed programs to deliver DSMES virtually or via telehealth when previously they weren't able to. They were excluded from the list of eligible telehealth providers. And telehealth has been made so much easier for people. They can access it in their homes rather than having to go to another site to get the service. So we're really working to advocate for permanent changes to telehealth that keep these flexibilities in place that we know are so beneficial to people with diabetes seeking care. We also work on the Treat and Reduce Obesity Act. This is another piece of federal legislation that ties in with what we're doing. We're monitoring drug pricing legislation. There's legislation that addresses social determinants of health. There was some legislation around surprise medical billing a little while ago in previous Congresses. And then also there were some different pieces of legislation from some of our partners like the American Pharmacists Association and in the Academy of Nutrition and Dietetics that we track closely as well. We do a lot of outreach to the administration and regulatory agencies, as I mentioned, like CMS, the Food and Drug Administration, and others. And then we support our members as best we can in terms of grassroots engagement, looking at what's happening at the states. And then, as I mentioned, coverage and reimbursement is a priority. We've been looking at improving coverage under Medicare for CGM and insulin pumps. This is something that we're actively working on with our coalition. And we're starting to realize some of the success based on the example that I gave you previously. And it sounds like Medicare is open to having some of those additional conversations. We also, as I said, we work a lot in the prevention space too, working to always have communications with the Centers for Disease Control and Prevention and Medicare around national DPP and Medicare DPP, and then state issues. Here are some of the things that are coming to the top across the country. And I know you have different pieces of legislation or policy priorities that you're working on in Kentucky, but just and I know you're very advanced in some of the work that you've done. So states may be catching up with what Kentucky has already done, which is fantastic. Medicaid coverage of continuous glucose monitors of the national NDPP, National Diabetes Prevention Program, DSMES, other devices. So that's something that we're seeing across the country. Insulin copay capping legislation has also been something that we've seen as well. And then this National Clinical Care Commission, which I mentioned earlier, which I'll touch on in a little bit more detail, because this is a really interesting report that I would encourage you to take a look at, because it really makes some important recommendations of where we might go in the future. So this was, as I mentioned, a national commission that was formed for 3 years based on a piece of legislation that established the commission. And they had 3 years worth of activity. They collected data, they heard from all the federal agencies, and then they released this comprehensive report to Congress to make some recommendations about improving diabetes policy across the federal government. And so there were some big recommendations. A lot of them were broken down into 3 categories. Some were overall recommendations, including creating an Office of National Diabetes Policy, focusing on health equity. There were some recommendations about diabetes prevention in the general population. So overall, looking at things like nutrition assistance and SNAP programs, sugar sweetened beverages, environmental exposures for people that put them at risk for developing diabetes. Other things, there were a lot of recommendations around prevention, including coverage for A1C, screening for diagnosis under Medicare, some quality measures that have been developed to look at prediabetes, awareness campaigns covering all modalities for the Medicare Diabetes Prevention Program, and then recommendations for DSMES and DSMT, which looked at so a lot of the things that we've covered in our Expanding Access to Diabetes Self-Management Training Act, looking at administrative burden, prioritizing research to look at referrals and uptake of DSMES services. And so that was really valuable to see. And I know that the next speaker is going to talk about community health workers. And there was a few recommendations around really enhancing and implementing programs that would support the use of community health workers. So it's very comprehensive report, and I can drop it into the chat so people can take a look at it if you're interested. We also have some information on our Legislative Action Center, which I'll talk about in my next couple of slides, that it's a standard letter to Congress. You can go in, it talks about some of the high level provisions in the report that might be of interest to Congress. And so you can take a look there. So I'll share that with everybody as well. So talking about getting involved and taking action at the national level, here are some resources that I wanted to make you aware of that you can use if you want to get involved in advocacy or stay connected to what's happening in the national office. And as we know, and you know this more than anybody, you don't need to go to Washington to advocate, especially in this Zoom telehealth Teams world. We know that we don't have to be there in person. So there are a number of things that we can do. And we've got some engagement opportunities at the national level. We get asked a lot, how can I help to change policy? Really keep the conversation going with your colleagues. This is a link to our Legislative Action Center. It's where we have all of our policy issues posted. We've got pre-drafted letters to Congress. You can go in and just put your address, and they'll automatically pull up your member of Congress. There's all sorts of different letters, including the Expanding Access to DSMT Act, telehealth legislation, the National Clinical Care Commission report, all different information there. diabeteseducator.org/actnow. We've seen states do a letter writing campaign. So maybe if you're doing an event, encourage everybody at the event to send a letter via the Legislative Action Center. And we do track this and follow up with the congressional offices. Just here's what it looks like, just a few slides. So you just add your address and it pulls up your letter, and then it's easy to send. You can print it. You can also send a Facebook or Twitter message. And then we can track, here you can find information about legislation and track that. And then just a few suggestions in connecting with your legislators. I'm talking at the federal level, but this applies to the state level because I know you're working on state level advocacy today. Just to supplement that, same rules apply. Send a meeting invite, schedule a meeting, send a letter via the Legislative Action Center. If you go to your member of Congress's website, usually the first thing that pops up is a request to put your email address in to subscribe to their newsletter. And so that's a really good tool. There's all sorts of in-person or virtual town hall events that you can get informed of if you subscribe to their newsletter. And then here are just a few other resources for you if you're interested in getting more involved. And then we do have an advocacy forum on our platform, ADCS Connect. I would just, if you go to that page, you can subscribe down here at the bottom right, and you get all sorts of updates. I try to send out weekly or bi-weekly updates on what's happening in Congress or events that might be of interest to people. And then just a few more updates. ADCES hosts a quarterly advocacy town hall meeting. It's open to anybody who wants to participate. The information goes out on ADCS Connect and the Advocacy Forum, so it's important to subscribe. And we have scheduled Tuesdays, March 29th, June 21st, September 13th, November 15th, all at 1 p.m. Central Time. And so that's coming up. And we are also hosting a virtual public policy forum. It's our annual training event, and this will take place sometime in May. It's open to any ADCS members, so I would encourage you to look for announcements there. It's a really great event. We'll do some virtual congressional meetings as well, which we'll schedule on your behalf. And thank you very much for your time today. I think I've gone a little bit over, so I'm going to stop here. And thank you again, everyone.
Thank you for joining us, Kate. We appreciate the information that you've shared. And I believe we did have a comment in the chat to please share the resource information you mentioned, the link. There was some interest in that, so thank you. Our next two speakers explore the impact of community health workers on diabetes outcomes. Pam Spradling from the provider perspective at Big Sandy Healthcare, who will speak first, and then Whitney Allen will join us from United Healthcare, who will address the payer perspective. Pam and Whitney, welcome and thank you for joining us today.
Good morning. Thank you, Merritt. Can you all hear me okay?
Yes, ma'am.
All righty, good to go. Thank you all for having me today. I appreciate the opportunity to speak about something that I'm very passionate about, and that is the use of community health workers to affect change among the services we provide as healthcare providers, to increase the quality of healthcare that we provide, and also to just to help our patients to be able to navigate and manage their conditions on a daily basis. So thank you very much for having me here. I want to talk about how the difference, I guess, that community health makers make in the lives of our patients and on the individual healthcare organizations, but also on the overall healthcare system in Kentucky as well. When President Lyndon Johnson came to Eastern Kentucky in 1964 and launched his war on poverty from a front porch here in Martin County, which I'm in Floyd County this morning, but we serve Martin County as well in our service area. And as you know, at one time, Martin County was one of the poorest counties in the nation. And, you know, we've made a lot of progress over the years since President Johnson was here. And we have a lot of resources available to our patients with diabetes, but sometimes there's a disconnect between those resources and their availability and our patients' ability to navigate and to access those resources. There are a variety of barriers that keep them from being able to do so. Here at Big Sandy Healthcare, and I'll talk a lot about our program just to kind of share with you, but community health workers are being used across our state, and it's a field that's really growing in our state and across the nation. Community health workers are not a new concept. They've been around for many, many years and generations, helping people. It seems like there's always that person in the community who steps up as a healthcare advocate. And in our region of Appalachia, it was certainly Eula Hall. And here at Big Sandy Healthcare, of course, we lost Miss Eula earlier in 2021, back in May, but her legend still lives on here in our organization and in this region. And I'm sure that many of you know her and know of the work that she did. So here at Big Sandy, we've employed community health workers since 2017 to coordinate care for our patients with chronic conditions. And through home visits, clinic visits, telehealth, and phone calls. These CHWs provide our patients with health education, navigation services, and linkages to those community health resources that reduce those barriers to care related to social determinants of health. Some of these barriers include poverty, certainly in our region. We have very high rates of poverty. Food insecurity. We have a program now that community health workers implement that provides patients with vouchers to take to farmers markets and also to local food vendors where they can access healthy foods if they have these chronic conditions and suffer from poverty. Homelessness is a big issue in our area that we have to deal with. Lack of transportation, I know is a problem for many of you out there who are connected to healthcare organizations. Poor health literacy is very common across Kentucky, but it's very common in our area. We deal with a lot of patients who, quite frankly, don't have literacy skills at all. So health literacy, kind of even falls below that sometimes. And then lack of social support. I know this past week, we saw a story in the national news about a woman in another country, I think it was Italy maybe, who had died 2 years ago and was found still sitting at her table. And that story broke my heart, but my heart gets broken pretty much on a daily basis here in Eastern Kentucky because we have patients with diabetes and other chronic conditions that we serve who are very isolated. We have our per capita population here in Eastern Kentucky is not very high. And some of our larger counties, especially Pike County, there are just areas of Eastern Kentucky where there's nobody. There might be one house every 3 or 4 miles and there's nobody to serve these folks and to be with them. They don't have family, they don't have close friends, they've lost their connections to their environment and to their social support network as they've gotten older or gotten sicker. So we have many patients that are very, very isolated. So since 2017, we've been part of a research project through Marshall University School of Medicine to study the effectiveness of using CHWs to work with patients and to see what impact they can have on chronic disease measures. We've had a big focus on diabetes because we have such a high rate of diabetes here in our service area. We serve a 5-county area in Eastern Kentucky that consists of Floyd County, Pike County, Magoffin County, Martin County, and Johnson County. And our rates of diabetes and prediabetes are very high in this region. During the time that we've worked with Marshall, our CHWs have worked with over 800 patients, and we've seen statistically significant improvements in clinical indicators among the patients who've been diagnosed with diabetes and have been associated or attached to a community health worker. The Big Sandy region, again, like I said, has very high rates of chronic disease, but primarily diabetes, also hypertension, heart disease, and COPD. Of course, we have coal mines here in Eastern Kentucky. We have a lot of miners who have black lung disease as well. Many of our patients, what we find, and this makes it even more complicated for them to manage their chronic conditions, is that some of them have all of these conditions. They don't just suffer from diabetes. They have diabetes, they have hypertension, they have heart disease, which I realize is common. Then we add on, black lung or some other form of COPD. And our patients are very sick. Our population in Eastern Kentucky is very sick. Just to share a little bit of our data with you that's come out of our research project with Marshall, since we started working with these patients in 2017, 62% of our enrolled patients with diabetes have reduced their A1C by an average of 2.5 points. And in 2020, 74% of our patients with diabetes had an A1C below 9. Here at Big Sandy Healthcare, we are a federally qualified health center. So we use HRSA measures as kind of our baseline for staying under, and that number is 9, which we know is still too high for diabetes patients. And we're lucky and we're thankful that our CHWs have been able to have a lot greater success with that, because when I say below 9, many of our patients that we've enrolled came into the program with an A1C of 14 or above, and have managed to get their A1C down to very normal range in the 6.0 range or even lower. So we've been very successful. They have been very successful in the work that they've done. This happened in part because their health services were coordinated by a patient-centered care team. And that's kind of the model that we use here at Big Sandy. And that patient-centered care team includes a CHW as an integral part of the care team. It's not some separate, you know, oh yeah, there's community health workers over there. You can maybe get one of those. I'm not really sure about the program. That's not what our providers say. Our providers are champions for community health workers, and they want all of their patients attached to a community health worker. And it's difficult to keep enough community health workers to serve all the patients that they want us to serve. So we've been very successful in getting our providers on board and having them make those referrals to our program. So we're very thankful that they've included us, and that the more training that we provide for our CHWs and the more the more success we have, the more providers we've gotten on board with that. So these CHWs, you know, they work really hard to make sure that our patients get diabetes education, to make sure they can get fresh, healthy food, to make sure they get medication assistance, whether that means they can't afford their medications, we can help them maybe get those either through our 340B pharmacy program or through other programs that are available through our pharmaceutical companies or through funds that we have here at Big Sandy Healthcare to assist. Transportation to medical visits is very important for our patients. Again, they're very isolated in small communities out in these counties, and sometimes it's really difficult to get them to the clinic because many of them don't have their own transportation. And then all other kinds of support like employment, housing, those types of things. Our community health workers work daily to help with those kinds of issues for patients, and that's very important. We know how important those kinds of issues are to patients with diabetes or other chronic conditions, because it's really difficult for a provider to tell a patient, hey, you know, you've got to eat better, you've got to eat healthy foods, if that patient can't have any access to healthy foods. And so we have to make sure they understand what a healthy diet is for a patient with diabetes, but then also that they can get those foods that they need in order to eat that. Between January 2019 and June of 2020, the Marshall University cohort that we're part of reduced the total number of ED visits among enrolled patients by 93%, which we think is huge, and also reduced total hospitalizations by 82%. So we've been able to decrease the number of patients who are going to the ED for for various exacerbations of their chronic conditions. They're using primary care more, which is great, and not overusing or using, I don't like to say improperly, but anyway, using a higher level care than they may need to use for those exacerbations of chronic conditions. So, you know, for the patient, this means better health outcomes. They have that connection to their provider. They have that connection to another person in the clinic that they can contact. And our CHWs are clinic-based. Again, they are part of the care team. They are involved in the clinic. They're involved in case management, care coordination. And, they're an integral part of our clinic operations at this point and clinic flow at this point. So it means better outcomes for our patients. It means increased quality of life for those patients and their families. And for our providers, and this is something I really wanted to point out as well, for providers and healthcare organizations, this means less uncompensated care that we have to provide, which of course, helps us maintain our stability and sustainability as a healthcare organization. And it also allows us to access our increased quality and increased, meeting these measures, these HRSA measures or HEDIS measures also that I talk about. It allows us to access greater financial incentives that are available through quality awards and shared savings from accountable care organizations. And that's very important to an organization like ours. We're a relatively small organization, although we've had extreme growth over the last few years, but we're still, in the scheme of things, a relatively small organization. We have 8 clinic sites at this point in 5 counties, but we serve about 27,000 patients in Eastern Kentucky. And I think in 2021, that's going to be closer to 30,000. So we're excited about that. We're excited about the number of patients that we can work with. We need more community health workers, obviously, when we're dealing with a patient load that large. And then this kind of program and having these community health workers, it also leads to greater patient satisfaction and greater provider satisfaction. Our providers love serving our patients, and they understand the needs that they have, especially those needs like I've talked about, those social determinants of health needs. And again, it makes it really hard for them to feel like they're completely serving that patient if they're providing advice or guidance that they know the patient can't meet. They know the patient can't get healthy food. So, like, why am I telling this patient this? So, that's really, as they work hand in hand with our community health workers, that really has provided a lot more satisfaction in their job for our providers. They feel like that together as a team, we are really able to serve this patient well and provide quality services for those patients. And that's translated to increase patient retention and also to increase provider retention for our organization. There's been a lot of capacity built around community health workers over the past few years in Kentucky. The Kentucky Department for Public Health convened a CHW advisory work group a few years ago. That group meets regularly to advance the CHW profession in Kentucky. Again, it's been around for a long time, but we're finally getting the recognition that we so deserve. I say that jokingly, but in the past it has been kind of a profession that's been overlooked somewhat. So we're so glad to finally be recognized and have CHWs be recognized as a credible profession in healthcare organizations in the state. The Kentucky Association of Community Health Workers was formed, I think back in 2016, to advocate for and to promote CHWs as a profession in the state. And the association views community health workers as that missing link between providers and the patient, just as I sort of gave examples of earlier. And that relationship plays a really key role in improving the health of our patients and of our communities. The effectiveness of CHW programming is dependent on many factors, probably none of which are more important than quality training. In Kentucky, our CHWs, we've been very lucky, very fortunate, thanks to the work of not only the work group, but also the Appalachian Kentucky Healthcare Access Network and some other organizations in Kentucky that have provided access to competency-based training for community health workers. I know our organization has taken advantage of that training over the years, and it's been they've been very successful in providing those skills and that training for our CHWs. They have the work group developed 8 specific core competencies that the training is based on, and those include public health concepts and approaches, communication, organizational and community outreach, care coordination and system navigation, health coaching, advocacy and community capacity building, legal, ethical, and professional conduct, and documentation, reporting, and outcomes management. So CHWs in Kentucky are now eligible to be certified through the Kentucky Department for Public Health once they can demonstrate those approved CHW core competencies, either through training or experience. So there are 2 tracks to the credential. And we feel like that credential, it's given our CHWs more credibility in Kentucky. And so I think that has helped us especially be able to work our way into the healthcare organization and to becoming that integral part of our healthcare organizations, because providers, sometimes they're really looking for something like that. They want to know that we're providing that training, or that our CHWs have gotten some kind of training, and that they have that credential that helps us to build that credibility with our providers and our other clinic staff too as well. So to maintain their certification, CHWs complete 10 hours of state-approved continuing education units every year. So that helps us to make sure that they stay up to date on changes in healthcare, up to date on guidelines, even though they may not be the one to teach that or provide that, but just to make sure that they have good general knowledge of how to work with patients. I'll switch gears just a little bit and kind of really get to what I want to talk about today, and that is, how do we sustain this? Here at Big Sandy so far, we have primarily sustained our program through grants, and we've been very fortunate to have multiple grants to sustain our programs, and I know others in the state are doing that as well. We also have tapped into Medicare for those patients who are covered by Medicare. We're able to provide chronic care management services, and we have structured our program around that program, that Medicare program, and so that we can access reimbursement through Medicare for those patients who are eligible. But there needs to be more. In order for CHW model to remain viable in Kentucky, we have to have a sustainable stream of revenue. Let me repeat that. We must have a sustainable stream of revenue to support CHW programming. While most CHW programs, like I said, are grant funded, we have to facilitate payment models in order to continue this important work and to improve the health and lives of the people we serve. So today, on Diabetes Day in Kentucky, I call on our state legislature to consider a plan that will provide much needed reimbursement for the services provided by community health workers, Medicaid managed care organizations in other states around us, including Ohio and West Virginia. And I don't mean to make that sound bad, but come on, West Virginia. They've developed successful mechanisms for reimbursement that are robust enough to lead to sustainability for community health worker programs in their states. And it's time for the MCOs in Kentucky to step up to the plate and provide the same security for patients with diabetes and other chronic conditions. In the words of the infamous Eula Hall, one of the strongest advocates for healthcare quality for all people that I have ever had the pleasure of knowing and working with, we have to fight like hell, and those are her words, to make sure every Kentuckian with diabetes has access to the care they need to live a long and healthy life. Thank you.
Thank you, Pam, for sharing all the great work you're
Yeah,
doing.
there you go, Whitney. Hi.
In Kentucky. Hey, it's incredible data that you shared and outcomes for what your team is working on.
We're excited. Yeah, we're working hard.
Good. Well, good morning, everyone. My name is Whitney Allen. I'm the Director of Enrollee Services and Advocacy for United Healthcare Community Plan in Kentucky. I'm also proud to serve as the current president for the Kentucky Diabetes Network. And I am excited to be here with you today, virtually surrounded by diabetes advocates, and highlight the great work that community health workers are doing around the state in improving diabetes outcomes. Community health workers are trusted community partners who utilize a unique, non-traditional approach to care for our members, and they are critical to improving care access and ensuring that our members receive the care they need when they need it to manage their conditions, including diabetes. United Healthcare is honored to have the opportunity to work with Kentucky Diabetes Network to address how diabetes impacts our underserved communities. And additionally, we're working to support health equity and the need for community health workers across Kentucky. CHWs are trusted frontline public health workers that deeply understand the communities and people they serve, and Pam provided some excellent examples of that. CHWs really serve as that link between healthcare and social services systems to support access to services that individuals really need. And research done to date has identified that CHWs can help improve health outcomes and lower healthcare costs for the Medicaid population. Pam shared some great numbers, and also a recent study utilized CHWs in a neighboring state. Emergency room department visits and hospitalizations decreased, and there were healthcare savings that were achieved for members. So at the heart of United Healthcare's mission is to help people live healthier lives and to help make the healthcare system work better for everyone. And we know that by working together as a community, we can achieve through those partnerships. But on a recent America's Health Rankings report, and what Dr. White referenced earlier, shows about 13% of adults in Kentucky have diabetes. We rank last nationally in factors that contribute to diabetes, including exercise, fruit and vegetable consumption, and physical inactivity. But however, working with like-minded organizations throughout the state, including Kentucky Diabetes Network and many other partners that are here today, we have started to make significant strides in healthcare in the Commonwealth. United Healthcare, we are supporting UK Barnstable Brown Diabetes Center in offering the Diabetes Prevention Program, DPP, in rural areas through a partnership with county extension agents that previously didn't have any access to DPP programs in those areas. And to address the need for trained healthcare workers, including diabetes prevention, education, and care, we've partnered with the UK Center of Excellence in Rural Health to improve the rural health workforce in Kentucky, and we accomplish this through community health workers. So in Hazard, we are providing high school students with resources to complete a tuition-free community health worker curriculum at Hazard Community and Technical College's K-Tech program. It's taught by industry experts from Kentucky Home Place. And last year in 2021, we were proud to have our first graduating class, and we're excited to see the program continue and to see the impact that it's having in Eastern Kentucky on workforce issues and also improving health outcomes through the use of community health workers. And we've recognized the important work that community health workers do and value them so much that we have hired our own team of CHWs to serve our Kentucky membership across the state that work as part of our integrated care team. I'd like to share a quick story about the importance of CHWs in the Commonwealth. Kenyatta, a United Healthcare CHW, working with a member on his blood sugar monitoring. He was trying to get approval for continuous monitor because of his hectic work schedule. But Kenyatta helped the member with finding a continuous monitor that was covered under the plan. And then together, Kenyatta, the member, contacted the provider office to assist in understanding what was needed for the member's monitor request, and really had a huge impact on his life and his lifestyle. But community health workers, they're able to take the time with members, showing care and compassion and focus on addressing the members' needs to ultimately improve their health outcomes. So in recognition of Diabetes Day at the Capitol, I look forward to working together, developing integrated whole person care approaches to support the fight against diabetes. And it's really through open dialogue with one another that we will innovate to help provide the quality care that all people deserve and to help build strong and healthy communities. So thank you. Merritt, I'll turn it back over to you.
Thank you so much, Pam and Whitney, for highlighting the important difference that community health workers make in the lives of the people they serve and work with. We really appreciate you being with us today to share these powerful stories. Gary Doherty with the American Diabetes Association is our next speaker. ADA provides education to the public about diabetes and works to help people living with diabetes or who are at risk for developing diabetes through funding research to manage, cure, and prevent this chronic disease. Gary will now share the latest state government affairs information from ADA. Gary, welcome.
Thanks, Merritt, and thanks to everybody for joining this morning. I'm glad to be a part of the program, and like many of you, only wish that we were gathering together live and in person. And as we said last year, and we'll say again this year, hopefully next year. Next slide, please. To get started, I just wanted to share the mission of the American Diabetes Association, which is to prevent and cure diabetes and to improve the lives of all people affected by diabetes. Next, please. We pursue the ADA mission in a variety of ways. In my capacity as State Director of, or Director of State Government Affairs, I represent the association in our advocacy arena, including lobbying on behalf of ADA's legislative and regulatory priorities. Many of our priorities fall under the Health Equity Now umbrella. Health Equity Now is a national platform that ADA created to ensure that all people living with diabetes and the millions of underserved Americans who are at greatest risk for diabetes have access to health resources that are too often unavailable to them. This platform guides our work to address many challenges that people with diabetes face, accessing the tools and the resources they need to live healthy lives. Next, please. As part of the Health Equity Now initiative, ADA crafted a Health Equity Bill of Rights to serve as guidance to address these inequities. 10 fundamental rights are outlined in the Healthy Equity Bill of Rights, including the right to be able to afford the cost of prescribed drugs, access quality health insurance, avoid preventable amputations, and access to the innovations needed to manage diabetes. Next, please. The first right listed is the right to access insulin and other drugs affordably. For Americans with diabetes, the cost of care, as we all know, is staggering, and increasingly it is out of the reach of many folks. Diabetes is the most expensive chronic condition in the United States, costing $327 billion annually. The cost of healthcare is nearly 2.5 times higher for Americans with diabetes than those without diabetes. People with diabetes account for 1 out of every $4 spent on healthcare in the United States. And perhaps most startling, 1 in 4 insulin-dependent people with diabetes ration their insulin due to financial difficulty. Next, please. And that's why the American Diabetes Association supports both House Bill 42 and House Bill 90, as Representatives Minter and Bentley described earlier this morning. These bills build on the success we had last season, passing legislation to limit cost sharing on insulin at $30 per 30-day supply for those on state-regulated health plans. The governor mentioned this at the top of the program, and it was a key success for folks in Kentucky. House Bill 42 creates programs to help those who have urgent and ongoing needs for insulin. The bill is patterned after the Alex Smith Insulin Affordability Act, which was passed in Minnesota and named for the young man who, after aging off his parents' insurance, rationed his insulin due to its high cost, and unfortunately lost his life due to diabetic ketoacidosis. And House Bill 90 would set a copay cap of $30 on non-insulin medications used to treat diabetes, as well as certain diabetes supplies such as blood glucose monitors, including continuous glucose monitors, monitor supplies, medication injection aids, syringes, medication infusion devices, pharmacological agents for controlling blood sugar, and orthotics. Next, please. Among the other bills ADA is supporting this session are Senate Bill 126, which is the Senate version of House Bill 42. That is sponsored by Senator Wheeler. And House Bill 174, which would extend postpartum Medicaid coverage for new mothers up to 12 months after the last day of pregnancy. Access to care during the postpartum period is especially important for women with serious and chronic conditions like diabetes and gestational diabetes, and can impact maternal health outcomes. Additionally, postpartum coverage will extend access to mental health care, which is important since postpartum depression is fairly common in women with diabetes. House Bill 174 is sponsored by Representative Mackenzie Cantrell and has already passed the House and is awaiting a vote in the Senate. ADA continues to evaluate bills as they are introduced on a daily basis, and undoubtedly we will engage in some of them during the legislative process. Last slide, please. We do need your help. As both Representative Bentley and Minter indicated, and they are outstanding advocates for Kentuckians with diabetes. I can't tell you how rewarding it is to work with each of them to advance important diabetes-related legislation in Kentucky. But legislators need to hear from their constituents about how important these bills are. If you're not already an ADA diabetes advocate, I would encourage you to go to diabetes.org/advocate sign up, and you will get updates about key legislation and opportunities to engage. So I hope this update has been helpful. And again, I appreciate the opportunity to share some time here with you this morning. I've learned a lot already listening to the other speakers, and looking forward to hearing from the remaining speakers of the day. Thank you.
Thank you so much, Gary. Gary's been a contributor to Diabetes Day at the Capitol through the years, and we appreciate him juggling a busy schedule to be with us again. You know, I think so many of our speakers are juggling a lot of commitments, and we appreciate the time they've set apart in their schedule just to be with us today and share valuable information. Julie Babbage, the Executive Director with the Diabetes Patient Advocacy Coalition, joins us now with her insight on proposed legislation from the DPAC perspective. DPAC is an alliance of people with diabetes, caregivers, patient advocates, health professionals, diabetes organizations, and companies, all working collaboratively to promote and support public policy initiatives to improve the health of all Americans living with diabetes. Julie, I'll turn it over to you. Thank you for being with us today.
Absolutely. Thank you so much, Merritt. Really appreciate that introduction. And today's presenters are all doing incredible work. I'm grateful just to get to share with you some additional perspective from the advocacy angle. My name is Julie Babbage. I'm the Executive Director of the Diabetes Patient Advocacy Coalition, DPAC, and we focus on access and affordability for patients. Our mission could probably be summed up by, I think it was Pam's point, I think you were quoting from someone else who said that we're gonna fight like heck to make sure that people with diabetes have access and tools and resources and treatment they need to live long and healthy and productive lives. And that's a really great way to say it. So we do that working nationwide across states to pass good legislation and empowering advocates along the way to speak up and to share their story and to really drive the change. Gary's point just now about how it makes such a difference to be involved and for legislators and lawmakers to hear from you as individuals is so true. And I'll touch on that a little bit later on. But some of the work that DPAC does is helping people who lead everyday busy lives, but are deeply passionate, like so many on this call about diabetes, helping them to speak out and to share their stories and to be involved. And we do that through educational events, through calls to action on bills that are moving, and other work. So again, I'll touch on being a DPAC champion in just a couple slides. But I'll go ahead and move to the next slide. I mentioned that we work nationwide, which of course includes Kentucky, my home state. And I am coming to you live on this lovely day that is teasing a little spring for us. But you see here that we have a scorecard, and we do this across the nation where we're looking for specific bills to kind of judge where you are and where you stand. And Kentucky, which is not the case as we've seen in other presentations, is actually a leader in diabetes in a lot of ways from a legislative standpoint. And we could do a lot more, as all the other speakers have mentioned, to improve our numbers and some other studies. But this slide is really encouraging because it's showing you just how many bills that we've passed through the years. You see a brief case on two of those pieces. So the diabetes supplies copay cap, which I think was just mentioned, House Bill 90. Thank you again to Representative Bentley for sponsoring this legislation. He has been a great advocate, and many of these check boxes are his bills, along with Representative Minter, who has also been a wonderful champion for people with diabetes in the Commonwealth. And also on there is rebate pass-through. You know, some of the subjects are more self-explanatory than others. This is one where it takes a lot to try to really delve through the complicated pricing system in America and figure out why our drugs are costing so much. And so this is a bill in the Senate by Senator Meredith, Senate Bill 134. And I'm going to dive into this subject for the majority of my presentation briefly here. If we could go to the next slide. And if we could play this explainer video.
Millions of Americans rely on medications to manage their health, but existing rebate rules mean higher costs for people with chronic conditions like diabetes. Before patients are able to purchase their medicines, insurers and pharmacy benefit managers negotiate prices with the pharmaceutical company. Pharmaceutical companies provide rebates to reduce the total cost for many medicines. However, those savings are often not passed along to consumers.
Oh, that's okay. We don't have to start over. That's close. Or you could maybe skip to the
medications to manage their health. But existing rebate rules mean higher costs for people with chronic conditions like diabetes. Before patients are able to purchase their medicines, insurers and pharmacy benefit managers negotiate prices with the pharmaceutical company. Pharmaceutical companies provide rebates to reduce the total cost for many medicines. However, those savings are often not passed along to consumers. With rebate reform, middlemen would be required to pass through those savings, making drugs more affordable for patients. Supporting rebate reform puts patients first and promotes access to medicines they need. Join the fight.
Awesome, thank you. And actually that little hiccup was helpful because sometimes it's a lot of information quickly to try to convey in 48 seconds there. So if you could go to the next slide, rebates are just a complicated process, but Senate Bill 134 is basically saying rebates, which sound like a good thing, are actually one of the factors driving up costs in our healthcare system today. So what happens is a manufacturer who's making the drug wants to get it to as many people as possible. And so they want to get covered by insurance companies, and insurance companies and PBMs are working together to figure out which drugs are going to be covered, what the costs are, et cetera. And so as an incentive for their drug to be covered, they're offering steeper discounts big time. So you see in this current state example, retail list price is $150, just for this example. The rebate is $60. And so the insurance then gets the discount there, $90, right, is what they're paying for a drug. But then the patient goes all the way back up to retail price. And so they're not getting the benefit of that $60 that was already more or less given to the insurance and PBM piece of the pie. And again, a lot of money changing hands, which is one of the challenges of our unique system in the first place. But you see with reform that rebate, that $60 then gets passed through so that the patient is getting the benefit of the negotiated price. When we come to the counter to get our medication, we're not paying list price if we're in a deductible period, if we haven't met our deductible yet. Which is encouraging because there are so many folks on high deductible health plans. So really excited that Senator Meredith has decided to try to tackle this problem. West Virginia is actually the only state in the nation that has passed this legislation. If you go to the next slide, I've got, I think, a map on there with some of the other states who are currently considering similar legislation. And as we know, when states pass bills, it's not a cure-all. It's not for everybody, right? We need Washington to get involved so that everyone benefits from legislation like this. But the state passing this bill is a really good first step. Like I said, West Virginia became the first state in 2021 to require rebate pass-through. And then now there are many more state legislatures who are starting to see that this is a first step in having an honest conversation about why drugs are costing so much. It's a really opaque system. We're not able to see into it and really understand what's going on. But at least patients can benefit from, again, a negotiated discount that they should also receive. So that's what this bill is about. Really excited to share with you that legislation, again, as well as many of the others that have been stated that we are working on this session. And the next slide, please. So like I said, the Diabetes Patient Advocacy Coalition, we're a nonprofit, we work nationwide, and our job is to make it easy for people to be involved. This is a complicated process. Legislation is not straightforward. State capitals are all doing different things. Congress is doing its own thing. And so we exist to try to make it easy and fun to be involved in this process. We do that by things like virtual Hill Days, where we actually go to Congress and we have meetings with lawmakers. We can do those virtually and in person. Obviously we've been doing them virtually lately, but not unlike today, not unlike KDN, that takes you to the Capitol. You talk to legislators in person, share your perspective, share why this is important to you. So we do that in Congress. We also have brown bags where we're explaining really complex topics. I could spend half an hour talking about the bill that I just briefly spoke to. And so that's the purpose of our Lunch and Learns, where we're coming together to discuss concepts and policies that sometimes they just take time to really delve through all of the different pieces of. We do policy briefings in states where we come to the state, we invite all of our champions and advocates in those states, and we actually interview lawmakers on some of the work that they're doing, and then we talk too about all of our legislative priorities. So if you want to check it out, Diabetes PAC, Patient Advocacy Coalition.org is our website. We've got social media. We'd love to have those of you who are not involved signed up and ready to work with us this session, because I can tell you we're going to have several calls to action for a lot of good legislation and good work being done by the Kentucky General Assembly. And I think that is it. Thank you so much, Merritt.
Thank you, Julie. And we are running a bit ahead of schedule. So there is a question that has popped up in the chat that I will read, and we have time for you to be able to answer. And it's a very good question. What will keep insurance providers from just increasing their premiums, deductibles, thus negating cost savings through this legislation?
Oh, that is a great question, Jason, and not one that many people think to ask. So thank you so much for bringing that up. And that is actually one of the arguments against this bill from insurers and PBMs is if you're taking away the rebate, which we're using to keep your premiums down, we will then have to raise premiums for patients. There are a couple problems with that. One, if they're using rebates now to keep premiums down, I haven't had a premium go down ever. And so that seems to not be the case. We have a study, a Milliman study actually, that I can share too with our group today, that shows that if rebates were passed through, the cost to patients, to consumers, would be less than 0.1%. So we're talking a really, really minimal increase in premiums if this were to happen. The challenge with all of that money getting caught up in the middle is we don't really know what's happening to it. And those of us who have to go to the counter, who have to pay for medications, are subsidizing the system. And that's a really tough way for this all to work, is to more or less penalize those of us who are, have chronic conditions and need supplies and need medications. So let's see, Kim, or from the manufacturer from raising the medical costs. So that's another great example. So if we got rid of rebates and we started to have a really honest conversation about this is the cost of a drug, it's not inflated from this system over here, from this rebate that's happening in the middle, that's really hard to track and really hard to wrap our minds around, then we can start to have at least patients, right, are benefiting from that negotiation. And we can also start to have a really honest price about manufacturers and what their list prices are, which we know have also continued to rise. Everyone in this three-tier system loves to point fingers at each other, and nobody wears the white hat. So it's manufacturers versus PBMs and insurers, and everyone's saying it's their fault, it's their fault. Again, it's hard to start to understand the system without making incremental reform first. And this is a really good first step to say, okay, at least now patients get the benefit of the negotiated price. Now let's talk about all of the other problems that are driving costs up and how we can begin to address those. So a lot of the argument against is that premiums will rise. Again, our organization's standpoint is that we haven't seen premiums be kept low because of rebates in the first place in our estimations and in our studies. And furthermore, the study that I mentioned that says that if they were passed through, that increment would be nominal. So I hope that answers those questions, and really happy to continue the conversation with anyone who's interested.
Thank you again for joining us, Julie. You always help us make better sense out of things, as you said, that are so opaque. So we appreciate that insight and wisdom.
Thank you. I really appreciate it. Thanks for having me.
Our final speaker joined the Foundation for a Healthy Kentucky in 2016 as CEO after more than 30 years in public service, including a term as Kentucky State Auditor, 2 terms as Kentucky's Attorney General, and then serving as U.S. Representative from Kentucky's 6th Congressional District from 2004 to 2013. Welcome, Ben Chandler, and thank you for joining us for our call to action.
Mary, it's so nice to be with you, and it's great to hear all the other advocates today talk about their roles and the system that we're dealing with. And I think what Julie just crystallized in her talk was what a complicated system we have. It's a shame that it's so complicated, and I wish that we could simplify the whole thing. It isn't really anybody's fault, but we've been grappling with the system like this for a very, very long time. So we're stuck with the requirement of trying to get these measures in place that are really piecemeal, but we do the best we can, and we fight to try to make advances in different areas. Julie's father, Bob, she comes from a long tradition of working on diabetes. I'll never forget one of the first people to knock on my door when I got elected to Congress almost 20 years ago was her father, Bob Babbage. In tow, he had Larry Smith and Stuart Perry, who have been tremendous advocates for diabetes issues. And they have been champions, major champions for a very, very long time, along with a lot of the other people that we're talking, that we've been hearing from today. We've got so many challenges, and it's heartbreaking to see the toll the diabetes takes on our citizens here in the state. You all know the numbers. I think you've heard some of the numbers today. We have such a high rate of diabetes in Kentucky, and that has real costs, not only costs to the economy, but you've got human costs. You've got lives that are not going to be as well lived because of this. And the fact that people don't have access to life-changing and life-saving medicines because of cost is a real problem. And what we want to do today is encourage all of our folks who are interested in this. If everybody who had diabetes would all scream at once, we've got to have reform, it would be inevitable. We would absolutely get the reform we need. But one thing I can tell you is that your elected officials do listen to you. When you have something to say as constituents, they do listen. And if we can get everybody who cares about this to contact their legislator, again, as many folks have said, even I believe Representative Minter and Representative Bentley said this themselves, that they encourage you all to contact your legislators. We've got 138 legislators here in Kentucky. So we need a lot of them on board. We've got good champions in Representative Minter and Representative Bentley, Senator Meredith, and others who have really stepped up to the plate on a lot of these issues. But they need help, and they need us and all advocates to get together and to really make an effort to push these things through. House Bill 42 and House Bill 90 in particular have not been assigned to committee. So I call on you all to please specifically tell your legislators to get these bills assigned to committee. When that happens, we can get started on the real advocacy of pushing these things through. And we're very hopeful these bills will make a big difference. And we, again, hope that you all will respond to the call to action. Community health workers, I want to take a moment to just say about community health workers, I don't know that there is really a more important group of people in this Commonwealth when it comes to trying to push for better health. Eula Hall, Pam mentioned Eula Hall. She was a hero to so many people, certainly in the eastern part of the state, and I knew her. I remember her very well. So many people looked up to her, and her life was one long mission of mercy. And she is a beacon for community health workers in this state. What they do is they navigate for people who have such difficulty getting through what is a tremendously complicated healthcare system. Even sophisticated people have difficulty navigating their way through this system. And I don't know how the average Kentuckian can possibly manage their way through the system without the assistance of community health workers. So I just want to say, if there's anything that we can do to really affect healthcare in a positive way, we need to lift up the community health workers and get them some sustainable funding. It really is important, and it'll make such a difference in the lives of so many of our people. But we've got some special opportunities here in combating diabetes. It really is a mission of mercy. We've got so many of our fellow citizens whose lives are impacted in a negative way, in a very negative way, by this dreadful disease. We have some ways to combat it and to make their lives better. And we've got some impediments to adopting those things. We have the power to knock down those impediments, to move them out of the way of our citizens so that they can lead better lives. And I hope that everybody here will step up to the plate and call their legislators and tell them that we're talking about life or death here. We're talking about quality of life of our people. And there is nothing that you can think of that's more important than your health. So let's get together. Let's push this effort and let's get it over the finish line so that we can move on and accomplish a few other things. Thank you all for being a part of this. Very grateful to everybody who cares. Thank you, Merritt. Back to you.
Thank you for that call to action. This is the point at which, if we were there in person, we'd leave with our packets of information and go back and make those scheduled visits. Thank you again to Representatives Minter and Bentley for being with us today and for their work that they're doing every day on behalf of the citizens of the Commonwealth who are living with diabetes. Thank you to all of our speakers who made time to be with us today and shared very valuable information with us. So, as Congressman Chandler asked us to do, take action, contact your legislators. For more information on this, you can visit KDN's website at kydiabetes.net. We have information related to making those contacts with your legislators, how to find them, and also some great talking points. And if you do have questions, please reach out directly to KDN, and we'll be happy to work with you to make those important contacts. Thank you all. Have a wonderful day, and thank you again for joining us.